Hello, everyone. Good afternoon or good morning. Welcome to the Model Law Knowledge Lab on overdose prevention and treatment in correctional settings. I am Becky Rose, the Senior Director at Rulo Strategies. I am part of the team that's supporting the Legislative Analysis and Public Policy Association, otherwise known as LAPA, to bring you this Knowledge Lab today. I am joined by my colleague, Tara Kunkel, who's the Executive Director at Rulo Strategies, who you will hear from today throughout the discussion. So what are Knowledge Labs? These are virtual learning series that provide stakeholders with an opportunity to deepen their awareness and understanding of how model laws can assist jurisdictions in addressing substance use disorders. These Knowledge Labs are made possible by a grant from the White House Office of National Drug Control Policy. And I'd like to offer a special welcome to the staff from ONDCP here with us today. And thank you all for your support. In addition, we are joined by representatives from LAPA who have led this project on behalf of ONDCP. A very special welcome to Sarah Kelsey, Susan Weinstein, John Woodruff, and Heather Gray, who are joining us today. The LAPA team will be engaging throughout the conversation in the chat and answering questions and sharing relevant resources. Just a little bit of housekeeping before we get started. All of the attendees are muted, but we can interact with you all through the Q&A box and the chat box in your Zoom control panel. So if you have any questions or any issues, you can directly chat one of us, or you can type it in the Q&A box and we will try to get to your questions. If you have any logistical questions and want to send an email because you can't access that, you can just reach me at rebecca.com. During our discussion today, you're going to hear from experts on overdose prevention and treatment in correctional settings efforts. Thank you to those of you that had shared questions during the registration process. We have shared those questions with the speakers, and hopefully we'll be addressing these throughout the conversation. But in addition, we encourage you to ask questions in the Q&A box, and we will get to them at the end of the conversation. We will also be posting relevant resources in the chat box and throughout the discussion today. This session is being recorded and will be made available on the Knowledge Labs tab on LAPA's website in a few short days. Now I'd like to introduce our expert moderator today, Regina LaBelle. Regina is a distinguished scholar and director of Addiction and Public Policy Initiative at the O'Neill Institute at Georgetown University Law Center. She is also the founding director and teaches in the Master of Science in Addiction Policy and Practice program at Georgetown University's Graduate School of Arts and Sciences. Regina served in the Biden administration as acting director of the White House Office of National Drug Control Policy. There, Regina developed the Biden-Harris administration's initial drug policy priorities, which included a historic focus on harm reduction services. Regina, welcome, and I'll pass it to you.
Thanks so much, Becky, and thanks everyone for joining us today. I think this is such an important topic, and I'm so glad that LAPA is sponsoring this and that Rulo Strategies is putting this together. What we're going to do in today's discussion is we're going to learn from experts with respect to their efforts to provide treatment in correction settings, and learn why it's so important to address this issue and share ideas on the various approaches to initiating this work in states. So what I want to start off with is just giving a little bit of scene setting about why this work is so important. If you work in this area, you understand how rates of overdose death in the reentry population are so high. So I'm going to go over just a few statistics and some research that we've done. First of all, the rate of intoxication deaths more than quadrupled in jails from 6 per 100,000 in 2000 to 26 per 100,000 in 2019. Almost 40% of the people who died in local jails in 2019 had been held in a jail for 1 week or less. And we also know from research that incarcerated people are up to 40 times more likely to die of an opioid-involved overdose within a few weeks after release. The research that we've done at the O'Neill Institute has shed a light on this issue. We did some research from 2015 to 2020 of all civil litigation cases that involved deaths in custody. And we found that they represented almost $300 million in awards in those civil litigation cases. Now, suicide was the leading cause of death in these cases and accounted for claims in about a third of the cases we reviewed. Drug-related deaths, including overdoses and withdrawal, accounted for about 20% of all the lawsuits that we looked at. And again, just like the data that I mentioned first, almost a quarter of in-custody deaths occurred in the first 24 hours after arrest. We know that the lack of treatment access and the lack of withdrawal services causes lost lives. It also costs taxpayers. Now, in 2022, DOJ made it clear that the Americans with Disabilities Act applies to individuals in treatment or recovery from a substance use disorder. And they've taken a number of enforcement actions across the country. DOJ's guidance, as well as litigation that's been brought against jails, prisons, and other public accommodations, has made it clear that there are legal protections, which include constitutional protections and the ADA for people who are receiving medications for opioid use disorder. So through a combination of legislation, litigation, and gubernatorial leadership, more states are expanding access to this life-saving treatment in correctional settings. Now, at the O'Neill Institute, we also examined state policies in all 50 states, and we just updated this review in February of 2023. We found that through this combination of legislation, litigation, and executive acts, it's led to increased access to medications for opioid use disorder. And in 2022, Colorado passed a law to expand access to all 3 forms of FDA-approved MOUD in their correctional settings. This year, 2 more states passed laws to expand access to MOUD. That was New Mexico and Pennsylvania. But still, the work is not done. In 2021, the Jail and Prison Opioid Project found that just 12% of correctional institutions nationwide offered any type of medication for opioid use disorder. And while the states of California and Washington State have taken advantage of the 1115 waiver to start MOUD in corrections through Medicaid, this is really still a stopgap approach to resolving the issue of adequate healthcare in correctional settings. So today we're joined with this great panel to hear on the ground from them about exactly what they're doing in their states. So first, I want to introduce Annie Romanus, who's the Executive Director of Addiction and Mental Health Systems for the Vermont Department of Corrections. She was appointed this position in 2016, and she's worked in the field of community-based integrated mental health and substance use disorder treatment with the criminal justice system for 20 years in the state of Vermont. Next, we have Chief Deputy Jeff Stober, who's the Chief Deputy of Research, Development, and Major Projects for the Franklin County Sheriff's Office in Columbus, Ohio. Now, before he took his current position, he managed the office's largest division and was responsible for the custody and care of more than 2,000 incarcerated people in Franklin County's 2 jails, and for the security of all individuals working and visiting in Franklin County government buildings. And then next is Carrie Hill. Carrie is the Executive Director of the Massachusetts Sheriff Association and the Chief Jail Advisor to the National Sheriff's Association. She's dedicated her 30-plus career providing criminal justice consulting and professional development seminars in correctional law to educate and empower those working in the correctional industry. And as you can see, we have a great lineup. And to start our conversation today, I want to give each speaker a chance to welcome our attendees and share their perspectives on this issue. So we'll start first with Annie.
Good afternoon, everybody. I am absolutely delighted to be here, and I am excited to have a very stimulating conversation. So my job here is going to try to rein myself in so that I don't talk very much, so that I allow others to talk and for us to really have a dialogue. I think Regina's question, I always hear that question as, who am I and why do I do what I do? For me, it's very simple. I am very fortunate in that who I am is absolutely what I do every day. I'm a child of the 60s. I grew up in New York City, and I was surrounded by crack cocaine, heroin, and all types of drugs. I saw how it brought down families, friends, and politicians. I decided to make this my life work based on that experience. And I can also add that Drugs have touched my personal life as well, my family's life. And I come at this work with really a zealot's passion. I often think of myself as Joan of Arc burning at the stake because I need to light the way and lead forward on the path. So for me, it's a life of passion and purpose, and I'm just so happy to have found this space.
Thank you so much, Annie. So next we'll hear from Jeff.
Hi, everybody. Welcome. Jeff Stobart. I am the Chief Deputy here in Franklin County, Columbus, Ohio, ground zero, central and southern Ohio of the opioid epidemic. This is something we've been dealing with, obviously, in this neck of the woods for quite a long period of time. We were blessed, and one of the things that we'll talk about as we go through is we're blessed to have just completed at least phase one of a brand new facility that really has been designed from the word go to deal with the folks that are suffering from basically mental health issues, serious mental illness, as well as those with co-occurring drug and alcohol issues. So I'll get a little bit into some of the things that we've done here. Things like creating a medically managed withdrawal pod specifically within the facility. Again, welcome. I want to be brief so we can get to everybody's questions. I appreciate you having me here today. Thank you.
Thanks, Jeff. And last but not least, Carrie Hill.
Thank you, Regina. Welcome, everyone. As you've heard from everyone today, we're thrilled to be a part of this and to be part of the dialogue. I like Annie. I love Annie, that energy and that passion. And I don't think there's anyone on this call who doesn't share that same passion. My history in this area, I am an attorney, and I've dedicated my now 30 plus years to this area of really working in the area of policy development and really looking at this also from a risk management point of view in our nation's jails across the United States. I'm privileged to be the executive director here in Massachusetts. And I'm so proud of the leadership of our sheriffs here in Massachusetts and the work that they've been doing in this space. And I'm also really proud to, in my role with the national sheriffs as the chief jail advisor, to really talk about how we're really starting to see this paradigm shift and culture change with our nation's sheriffs. Our nation's sheriffs oversee approximately 80% of the facilities in the United States. And to Regina's point, there is more work to be done. And that's why this seminar is really exciting, so that we actually have an opportunity to share some of our experiences, but also to hear from you where there are gaps and where we can work to try to really, at the end of the day, improve outcomes for those returning to our community, and most of all, to prevent deaths. Regina, thank you for this opportunity, and back to you.
Thanks, Karen. I want to start with a question for Annie first. We know that Vermont has mandated all 3 forms of medications for opioid use disorder in all the correctional facilities. Can you tell us a little bit about how the legislative process by which you got to that point, and what your lessons learned are that you can share with folks on the webinar?
Sure. Thank you, Regina. Yeah, I really stepped into a hornet's nest when I started my role. There was pent-up demand in Vermont that was legislatively driven and pretty ferocious. I think at the time of the beginning of that session in 2007, there were over 8 bills in both houses that were working their way to the floor. The commissioner sent me in to basically try to rein all of this policy development in and to make it science-based and as compassionate and humanistic as possible. I was really fortunate because of that pent-up demand. It's better to have a lot of energy poured on top of you versus none at all. I was very cognizant of the fact that we were poised to become the first state in the nation to actually pass a law directing the Department of Corrections to provide the same care as the rest of the citizens of the state. So it was a big responsibility. I was happy to share that responsibility, which was strategic, with all of the stakeholders. I really strove to have the most inclusive process as possible, to not leave anybody off the menu or the table. Everybody had to participate, and we often spent time outside of the committees of jurisdiction breaking bread in the cafeteria in the State House, working it out, word by word, sentence by sentence. It was daunting. It took the entire session, but what we were able to create has really, I think, informed the nation. I know that we worked with APA in helping create the model law that that's on the website here and that's available to all of you. But the overall lessons that I learned from that were simple. It's important to keep it simple in chaos. My guiding principles, which I never wavered from and which really saved me and protected me and the process and the department, was first, put patients first. This is about human beings. Never forget your humanity when you're working out the details. Second, as I've already mentioned, inclusivity, get everybody to the table. Don't let politics and personalities split the process. Third, be guided by science, not money, not politics. This is a tricky negotiation, but we have to be science-based and we have to defend what we do and to honor the patients that we're serving. We need to protect we need to protect individuals and we need to protect our states. I agree with Carrie. It's ultimately about a lot of risk management, but the best risk management is the best processes and the best laws and the best policy. So that's how I really threaded the needle, focusing on science and humanity. A perfect pairing, in my opinion.
That's great. People, inclusivity, and science, great guiding lights. Carrie, I want to go to you. Can you share your perspective on the legislative experience in Massachusetts and share any lessons that you learned?
So at that time, I was still with the National Sheriff's Association, but we were watching what was happening with Massachusetts. And in Massachusetts, it was a sheriff's-led initiative, which is one of the reasons why I'm so proud. So again, the sheriffs here in the state leading the way on medication-assisted treatment. And the bill was ultimately signed in August of 2018 for recognizing all forms of medication-assisted treatment. It started out as a pilot. We have 14 sheriff's offices in the Commonwealth here in Massachusetts, 13 that hold incarcerated individuals. So it was a pilot program. And so it was wonderful to be not only seeing what was happening here in the state, but nationally, all eyes watching how this was being led by sheriffs in their individual jails as elected officials. 5 initially of the 13 sheriff's offices were part of the pilot, 2 were added. And please know, all the other sheriff's offices may have already been doing MAT one form or another or interested, but it started out with 7. Fully funded by the legislature with a line item dedicated for all of the medications. Again, it was for maintenance for any individual who was coming in with a valid prescription. And if there were any questions, on that, they would work for those sentenced individuals returning back to the community. Again, were medically indicated. And then a very robust data collection project. Again, law signed in 2018 really kicked off in March of 2000. And I am proud, again, and honored to say that now in the state of Massachusetts, every sheriff's office is providing all forms of MAT where available in the community. For example, on Martha's Vineyard, there is no methadone. So therefore, if there was an individual who had the need for methadone, they would be moved to another facility. But again, that as we see with sheriffs leading the way, and part of that too, which has been incredibly helpful to the field, is the peer-to-peer learning with other sheriffs from other states, working with BJA, and they have a wonderful program, if you're not familiar with, whereby you can ask to learn from a program. So when we had our first sheriff sued in the United States for failing to provide medication-assisted treatment, Sheriff Elfo from Washington and his team flew out to Massachusetts to learn from Sheriff Katusian and his team about how to set up an MAT program. We have in Franklin County, which is small and rural, sheriffs who are leading that way, especially with OTPs as well, and now providing it. So again, what started out as a pilot with all 7 or with 7 now includes all 13 sheriff's office with a line item that continues to grow every year as we look at the expansion of providing medication-assisted treatment here in the Commonwealth in Massachusetts.
Great. Thanks, Carrie. Before I turn over to Jeff with a question, Annie, I wanted to ask you a follow-up. Carrie mentioned that there was a line item in the budget. How did it work in Vermont? Was there funding for the programs, the county-based programs?
Yeah, so I should start by saying our landscape is a bit different from Massachusetts. We're one of 6 integrated prison jail systems in the United States. We are the second smallest, and we are the second least incarcerated state per capita in the country. That said, we were funded through a line item in the budget. And we've had several permutations of that funding as MAT has gained traction, which I know we're going to talk about in your second round of questions. But yes, the funding came with the request, with the law, and then it was a bit of a scramble because the line item in the budget came from old tobacco money. And so we knew that was not going to continue. So we were already thinking about what's next, before we even opened the floodgates.
Great, thank you. So now I want to ask Jeff about Franklin County. Obviously, these are issues that they're not done in silos. They depend on community-based care. And Franklin County obviously does a lot of work to transition people from incarceration to the community. So you have a rapid resource center, reentry center in your facility. You've had it for a while and you recently opened the brand new reentry center. Can you tell us a little bit more about the reentry center? And do you think we can prevent disruptions in care all the way from intake to reentry?
Yeah, absolutely. I think what you heard both Annie and Carrie talk about is collaboration. And the collaboration, quite frankly, in this space is really the most important thing that can happen. The beginning of the opioid epidemic, to be very honest, we were fairly siloed. And what we stood up here in Franklin County was a pretty robust criminal justice planning board that basically crosses all disciplines, anything that touches the criminal justice system, from the courts to probation to obviously the sheriff's office, the public defender, the prosecutor's office. And that group of people really guides the criminal justice system here in Franklin County. We include community partners as part of that criminal justice planning board. And the priorities for our county are really established by that criminal justice planning board. In kind of response to that, those are the priorities that our commissioners are willing to fund. Our funding source is willing to do a lot for us. Very blessed to live in Franklin County, double AAA bond rated, a lot of national headquartered companies here. Obviously, if anybody's been paying any attention, Intel, and a lot of those folks are adding just enormous infrastructure here in Franklin County. So we're pretty blessed to have good funding. Our Rapid Resource Center really was spurned out of, no matter how well you do in a facility of our size, you're not going to catch everybody. And because folks are cycling through the doors incredibly quickly, we knew that we were missing people at intake who were not, let's face it, the folks that are cycling through the doors of our jail aren't always honest with us at intake about their medical conditions. So what the Rapid Resource Center was, a place that we established in one of our legacy facilities. We really took an existing space, cleared it out, but we stuck all of the community providers as well as peer supporters in that space. And folks leaving the facility could access the Rapid Resource Center, and they do little things to try to draw folks in. There's coffee, there's snacks. They can come in and charge their cell phones. But that's really to get those folks in the door to begin to connect them to the services that they may need in the community. In the Rapid Resource Center, they can get all of those things. We can provide them with clothing if they need it, housing if they need it, rides if they need it. And we can also get them connected to MAT and MAT services really on demand, right there from the Rapid Resource Center. Obviously, with the building and construction of what is now a state-of-the-art brand new facility, our Rapid Resource Center here at the new facility is still under construction. It's not quite finished, but it's a pretty unbelievable place. And really what we did was set it up almost like a Disney queue, where you got to go through the gift shop to get out of the building. So when we release people, we have a separate releasing lobby that folks go through, and they have to go through the Disney queue of the Rapid Resource Center to get out of the building. So that gives the folks, the peer supporters, as well as the staff that are working in that space, the ability to connect with folks who may not already be connected to services from one of our programs in the facility. It gives them a shot to get those folks connected there in that space.
Great. Thank you, Jeff. Annie, can you tell about your ideas and experiences on how to get correctional facilities to build SUD and OUD, opioid use disorder and substance use disorder treatment into their healthcare contracts, not only as a special service?
That's a big question. I'll start from the high level and then drill down. We do have a master contract in Vermont. We have, obviously, like most jurisdictions, we have a state law that's very prescriptive. We entertain competitive bids for all of our healthcare contracts. This law, Act 176, was passed and signed during the last year of an existing contract. So there were extensive and intensive contract negotiations alongside of the legislative process in anticipation of the bill gaining momentum and being passed into law. That said, one of the wrinkles that was definitely a lesson that I learned the hard way was that when you're working with a healthcare contractor, a national contractor, there are staff on the ground that you've developed very strong relationships with, hopefully, and who are doing the lion's share of the work in your jurisdiction. That said, they're caught between two masters, you as the contract monitor, and then their own corporate headquarters and layer above them. I felt that we had been incredibly clear about our intentions. Certainly the executive branch and both branches of the House and the Senate were very clear in what they wanted, and the citizens of Vermont were clear as well. That said, the corporate layer that I was dealing with was indecisive, and it was a struggle to get the spirit of the law operationalized into the facilities. So there was a bit of wrangling that occurred in the first quarter as we were in the initial 3-month transition plan before everybody could really wrap their minds around the implications of what had happened. Now, then you're talking about change management like location. It never goes away. Change management is constant. My experience in corrections is that as soon as you pin something down, it dissolves again. Somebody has to be the champion of this issue, and you have to be relentless, and you can never put down your spear, your magic wand, whatever your metaphor is, because there are forces to take it back. And we know that it takes at least 7 years for change to stick. And even then, there are erosive, corrosive properties happening that you might not see. But it takes relentless championing all along the way. You start out with acknowledging that it's specialty care. You start out by owning in the space that this is something new and different, scary, has all different kinds of meanings for different people, evokes things in people that are very powerful. You have to let all of that out and let people dialogue about it. You cannot shut it down. It just goes underground. But then you have to start pivoting to normalizing. And I tried to normalize not only in the culture, but also normalizing in operations, because there's obviously the medical clinical guidelines that have to be amended and braided and blended. And then there's the operations side that needs to be braided and blended. And then there's the heart and the head and the mind of all of these people working together and pulling and pushing. It's like a big tug of war. It's messy, really messy. You also have to pay attention to the financial, which Regina asked me about a few minutes ago. It was absolutely a metaphor and a signaling to the system when we were able to secure and embed the funding for this service, this medical service, within our base funding, because then it moved it from specialty care to business as usual. This is no different than treating diabetes. This is no different than treating chronic wounds or any other disorder. So we used the financial lever to also signal that this was not going away. And I was so excited when the DOJ and the ADA ruling came down, because then really the attacks that I had been receiving from the union, from whoever, about, oh, you're just addicting people, this is wrong-headed, blah, 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 no matter how you put the science in front of them, the conversation finally shifted, because this was so important and we had been on the right side of it. And that helped quiet all those naysayers. They're still out there. It's never gonna stop, but at least it's more tolerable and the volume has been turned down a little bit. So that's what I would say to answer that question, Regina. I hope I got to what you wanted.
Yeah, that was great. And showing the importance of leadership, always evaluating, figuring out where you're at, but that leadership piece is so important. And we've seen it over and over again in states that have robust systems. So Carrie, picking up on that leadership theme, in your work with National Sheriff's Association and the Jail and Justice Support Group, you've been working to build support for MOUD in jails. How have things changed over time in terms of buy-in among sheriffs for MOUD and evidence-based treatment?
Great question. And as you've heard, we're talking about culture, we're talking about leadership, and we're also talking about that need now more than ever to collaborate. Back in 2018, picking up where, again, our federal partners, BJA, NIC, the National Sheriff's Association with the National Commission on Correctional Healthcare worked together with also our other national partners and released in 2018, again, hearing from the field. Let me just say this. I think this is really key, is hearing from the field a need. We understood that there was an opioid crisis going on. It was new in communities as far as how to address it. And remember, jails are a reflection of our community. So what we're going to see in the community, we're going to see in our facilities. And hearing from the field and working collaboratively with our federal partners, we were able to put out the jail-based medication-assisted treatment, promising practices, guidelines, and resources for the field. Really a great tool to help our sheriffs and our jails across the United States to understand, number one, what is medication-assisted treatment? What does it consist of? How do you set up a program? What is it? What are the medications at that time FDA approved? What does it mean for pregnant people? And also to 5 centers of innovation across the United States. So jails across the United States that had already implemented a medication-assisted treatment program back in 2018. Now, mind you, again, it was very new to the jails at that time, really talking. Some of them are definitely on the cutting edge, but others just learning. So that was released in, again, October of 2018. Shortly, and let me just back up. In 2000, the National Sheriff's Association passed a resolution to support the use of, at that time, non-narcotic evidence-based medication for the treatment of opioid use disorder. So that was back in 2000. Now we start to see that, okay, now we need to provide guidance as we hear from the field. So the promising practices came out. In 2019, we took that old 17 resolution and expanded that with the national sheriffs to now recognize the use of all FDA-approved medications for the treatment of opioid use disorder. So again, another big shift, really sharing and alerting all of the sheriffs nationally that the National Sheriff's Association supports this. As we start to see, again, now medication-assisted treatment programs starting to start across the United States. We talk about our federal partners, this peer-to-peer learning going across the United States to help train other sheriffs who were interested in learning. One of the gaps that you know so well, and I so appreciate the work that you did with the O'Neill Institute, was the legal brief that you talked briefly about. So we were looking at gaps. Where are some of the gaps? And part of that was understanding. So we understand that medication-assisted treatment is voluntary. There may be those coming in on other substances, right, that may be going through withdrawal, and those that may not want to participate in a medication-assisted treatment program. So how do we address that? And again, hearing from the field, our federal partners came to the table, NIC, BJA, and put together this extraordinary group of addiction treatment specialists, individuals who were subject matter experts in jail administration. And now we have seen in 2022, the withdrawal guidelines that have come out for jails. So again, all of that as we start to see this progression and the sheriffs being part of that and at the table. In 2022, the National Sheriff's Association expanded that resolution now to make sure that it included not only all of the FDA-approved medications, but moved into MOUD discussion, recognizing for pregnant people, and also including withdrawal management as a part of that resolution. So we're trying to help to move the field. All of this happens together when we collaborate with our federal partners. One of the exciting things coming forth from as a result of the withdrawal guidelines is what I would call an RFP, a draft of some type of contract language that can be used for medical providers. So if you're putting forth and setting up like an MAT program, language that you could include in your contract, as well as language for the withdrawal guidelines, what could be in those contracts as well. And again, is there more work to do? There is, but we have seen this natural progression, and it's important to see the sheriffs helping to lead that and helping to train and to be a voice for all of our sheriffs across the United States. And again, connecting to peer resources when there are those that are interested in learning how others have done it and what they can do to move forward.
Thanks, Carrie. It was great. Sheriffs learning from other sheriffs has been really critical in moving this forward. And one of the issues that jail administrators, correctional healthcare folks talk about, and sheriffs is the issue of diversion. The medications, methadone and buprenorphine, are controlled substances, so that can be a barrier to implementing jail-based care. And so I wanted to ask Jeff what you have done in Franklin County to address those concerns about diversion in the facility.
Diversion happens in a lot of different ways. One of the things that we've tried to focus on, quite frankly, is, and it's hard work, and you just have to make the commitment to do it. This is, for us, it was about getting educated first. And quite, people forget sometimes we're cops. We're not addiction medicine specialists. We're not providers. Some of this stuff is not really in our wheelhouse. So it really took on the national level, with the help of the National Institute of Corrections, the national sheriffs, the major county sheriffs, us to begin to have the conversations around why this is so important. One of the things, and quite frankly, actually Carrie and I we're blessed just to get back from, is the large jail network, which is run by the National Institute of Corrections. It's quite frankly one of the best things that I do, and that's getting the sheriffs and jail administrators from the largest jails in the country all together. And diversion is a topic for every single jail administrator across the country, every single sheriff across the country. These are things that we do have to worry about. That being said, you really just have to put the work in. And again, we're fairly blessed here in Franklin County to have the funds to be able to commit to this. But this is, again, coming from that collaboration through our Criminal Justice Planning Board. These are decisions that are the best thing for our county and the decisions that are being made and the things that are being funded are things to prevent this. One of the big things, again, that we did here in Franklin County, obviously, again, talking about a brand new, shiny new building, having a medically managed withdrawal pod actually built into our facility. That medically managed withdrawal pod is an open bayed format where you have very clear lines of sight. That it has extra toilets, extra showers, all of those types of things that you would need in a space that's, you have people who are suffering from withdrawal or addiction. We have Gatorade machines that are going to be right in the pod so they can get their electrolytes, stay hydrated. We're thinking about those types of things. The guard posts are sized large enough for both security staff as well as medical and mental health staff to be embedded in that space. Carrie talked about your RFPs for your medical providers. We wrote directly into our medical RFP that our provider is required to have an RN in that space 24 hours a day, 7 days a week. So it's those types of things, and those things are expensive, don't get me wrong, but those are things that our county has committed to. The funding sources, our commissioners, and the guidance from our Criminal Justice Planning Board has made it pretty clear that this is a priority for us here in Franklin County. We have a medical triage room built directly into the pod, private interview counseling rooms built directly into the pod. We have a classroom built in for programming. It's on the second floor of our facility, so we're able to have skylights and start to bring natural light into the building and create a more normalized environment for these folks to recover. So this is really the first step for us in trying to get folks back on track behind the walls of the facility.
Thanks, Jeff. And I think it's not to be understated the importance of learning from one another and having some humility about what we don't know. I teach at Georgetown and I have humility every single day about what I don't know. So I think that's really great that we can learn from one another. And part of that humility also, Annie, I want to turn to you, is really talking about how we address the stigma that pervades every aspect of our community about substance use disorder. So how are you in Vermont going about addressing stigma with practitioners, with policymakers, and others who have to be involved in this important work?
Can I first sneak in a comment to Jeff? Jeff, I am so impressed with what you're doing. And what really just stands out so strongly to me is you are striving to treat people with dignity. And that is just really gold. So thank you so much. I'm proud to be another New Englander with you. Stigma, yes, I deal with it in the legislature. I deal with it in the community. I deal with it with medical staff, with correctional staff, with leadership in other areas of state government. It is a constant conversation. We will never get rid of stigma and bias. We need to let it out. We need to continue to dialogue, and we need to keep making compelling conversations and case studies about the science of addiction treatment. I just can't underscore that enough. There are still so many people, even though this has been such a part of national dialogue for so many years, there are still so many people who are just tuning in. And we can't get exasperated or frustrated. We have to treat every single person with the respect that they deserve, respecting the ideas that they hold, and then looking for an opportunity to create discrepancy. This is motivational interviewing 101 on the systems level of trying to create discrepancy in whatever they strongly hold on to jiggle that loose, to allow them to open up their frame, to accept that there might be other pathways to recovery that maybe they didn't need, but it might be possible that somebody else does. And this is the journey that I'm on every day, whether I just spent the morning testifying to Joint Justice. I didn't get direct questions about this specifically. People will call me up and ask me questions on the side. We had, of course, formalized ways of addressing what I'm talking about with correctional officers. I myself am the person who teaches at the academy with my mental health chief. We obviously had started including this kind of content a long time ago. And again, that turns into a very large conversation with whatever academy class we're working with. And we encourage people to debate with us. It's a Socratic back and forth, and we try to respect their views and leave them with whatever they want to take. And that happens over and over again at every level. I would say the biggest surprise I've had in this space is medical staff. I don't know about the rest of the states that are represented on this call, but we have been trying for many years to get this education into the University of Vermont Medical School and to make sure that this information sticks, that upcoming physicians and other providers, the School of Nursing as well, are given core curriculum that can be standardized. And then we need to line up preceptors. People need to have exposure to forensic medicine, and they need to have more exposure to doing this kind of work. It shouldn't be siloed off just in specialty care. So I'm on a revolution to introduce this across the state and to try to make sure that all places are welcoming to people with opioid use disorder or substance use disorder, not to dismantle the specialty providers, but to make sure that people are getting respectful and evidence-based care wherever they go, including a correctional facility.
Sorry, thank you. So we've had increasing rates of overdose death. We've had a couple months of leveling off, but over time, it's over 100,000 people. I remember when it was 20,000 and that was too much. It's too much now. How do you keep sheriffs engaged and feeling like they need to continue on this path that feels really tough sometimes?
So and I think part of it's because we have a passion, kind of what you're hearing from everyone. But part of it is that I'm relentless when it comes to these different initiatives, from the promising practices to changing the resolutions that have to be approved by the board at the National Sheriff's. But we are also training on this with the American Jail Association, with the National Sheriff's Association, with major counties, making sure that word gets out and raising this awareness. One of the other things too that I think is so important is we worked collectively, the National Sheriff's Association and NACO. And although we're not here to talk about the federal Medicaid inmate exclusion policy, part of that also too is with the MIEP, what can we do to try to get some of the laws changed so that those eligible for Medicaid or Medicare or CHIPS, if they're juveniles, would receive those benefits, right? Continuing while they are incarcerated. So our sheriffs have been at the table leading on that. And we continue to be part of those conversations so that, again, where eligible, those individuals could receive that. And that would be another resource to help our sheriffs across the United States, in states that is a possibility. In Massachusetts, I'm so proud. We're one of the 14 states at the time that had submitted 1115 waivers. And ours is also very inclusive of substance use, mental health, as well as now with the new withdrawal guidelines, making sure those are included. So we just keep coming before them. We talked about DOJ guidelines regarding the Americans with Disabilities Act Title II. We talk about the legal brief. We were part of the withdrawal guidelines and making sure, again, when those came out, that those were shared with all of the sheriffs across the United States and our jails. And then here's one of the other areas, and this, again, true collaboration, where the National Sheriff's Association, the American Jail Association, along with CNA and other of our national partners, are supporting the Jails and Justice Support Center, which will be set up, led by BJA and NIC, a hub, a resource for all issues to come surrounding jails for people to come to. And the first topic that we're going to be addressing is substance use and mental health screening for, as well as all of the extraordinary resources that are available. At the end of the day, we have to be a voice. We have to be a constant voice, but also showing that the individuals in our care, they're part of our community. They are our neighbors. They are our friends. They're family members. And the individuals returning to our communities, we want them returning in a better position than when they came to us. And that helps with public safety. So these conversations are a beautiful intersection of public safety, meeting public health, and improving outcomes for individuals returning to the sheriff's constituency. And for those individuals that they have jails that aren't run by sheriffs, again, we all share that same mission. Again, improving outcomes, improving lives, and just greater opportunities when people return. Again, we will continue to be advocates, raising that voice, whether it's on federal legislation, whether it's on the policy development that we've been fortunate enough to be a part of. But at the same time, when in fact we've had sheriffs, and we have, where there is a potential for liability, it's also making sure that they're aware of some of the federal partners and the resources that are available from the National Institute of Corrections, where technical assistance and resources can be made available for those facilities that are seeking assistance, whether it be peer-to-peer learning and or we really do need direction. And I want to share one more thing with you that will be available on the Jails and Justice Support Center when it's launched, and hopefully that'll be in November. Part of this is about culture and understanding about substance use disorder. And there's an extraordinary, we did some training on this at AJA and NSA, and I was privileged enough to do a piece with Dr. Shannon Robinson. So again, what Annie is talking about is really understanding addiction and also what substances can do to the brain. We have played that for everyone in our state, in Massachusetts, with all of our sheriff's offices. And she does an extraordinary webinar, just a 1 hour that really talks. And so I think whether it's Dr. Shannon Robinson or whomever, if we can also help to educate about understanding about substance use, about understanding what it does to the brain, that really will help all of us, right? Because we have officers, we have staff, we have sheriffs, who many of us, and Jeff pointed this out, that is not our specialty, but we all need to learn and to understand if we're ever going to change outcomes. So more resources coming to the field, and again, working to be a voice for the field as much as we can.
Great, thank you. So Jeff, I'm going to ask you the last question before I turn it to Heather Gray from LAPA. So you mentioned at the top, you're opening a brand new state-of-the-art facility in Franklin County that includes a withdrawal unit. And that withdrawal unit will be opening in the next couple months. Can you tell us what the vision is for that withdrawal unit and why is it necessary?
I think, at least here in Franklin County, we've gotten pretty good at what I would call the traditional MAT, getting folks on some type of going out the door, getting them connected to resources in the community where they can continue that treatment on the outside. But I think what folks sometimes miss is jails are a much different animal than prisons. And people get those confused sometimes. And I think one of the big things that when we started digging in kind of to the data here in Franklin County, and you talked about it a little bit, Annie talked about it a little bit, 73% of the folks that cycle through the doors of our jail in any given year, we're releasing them directly back into our community. They're our friends, they're our neighbors, they work in our community. And we've really taken the approach that it's in our best interest as a community to release those folks in a little bit better shape than we found. And it's really what Annie talked about. It's having the empathy to understand that everybody's path to incarceration is a little bit different. And I don't want you to get the impression that we got there overnight. Changing culture is a very difficult thing to do. You can get a PhD in organizational change. They don't give those away easy. So it's been a process for us. It's been a 8, 9, 10-year long process of beginning to change that culture within our facility to be able to do that. And really for us, it started with on the mental health side as much as anything, but it's again, it goes back to educating your staff on these issues. And it's not only about educating your staff within the facility, it's your funding source, your commissioners. They need to understand what's going on behind the walls of the facility. And one of the best pieces of leverage that we've had, Carrie keeps talking about the legal brief that went out. Quite frankly, after reading that legal brief, if you're not offering all 3 forms of MAT within your facility, I don't know what to tell you. You're making a big mistake. Unless you can clearly articulate something like Carrie's talking about, where there's not a methadone clinic within 100 miles of your facility, and there's no soft or warm handoff to a community provider. If you're not doing that, you're making a big mistake. And really with our folks here in Franklin County, showing them this legal brief, making sure they understood what the biggest thing you need to be doing is running a constitutionally run facility and making sure that you're doing all of the things that you're supposed to be doing according to the law. So that plays a huge piece in what we do, at least here in our facilities. It's been tough. I don't want anybody to think for a minute that it's something that happened overnight. A work in progress. We're still every day trying to get better, trying to do things better, and making sure that we're staying up with and being educated on what the best practices are. But again, most importantly, taking that patient-centric type of attitude. It's a clinical decision, and as a jail commander, I should not be making clinical decisions. I need to let my providers, and I have to trust in my providers that they're making the right clinical decisions in my facilities.
Thank you, Jeff. A lot of questions came in about data, measuring outcomes, and that goes to that culture change that each one of you has spoken about. Heather, can you talk to us about how best to approach this? What information should be gathered for outcome measurements? And if the other panelists have other thoughts on that, you're welcome to chime in as well.
Thanks, Regina. So as far as outcome measures go, LAPA has a document on our website, and I believe it'll be in the chat if it's not already, but it's a document that we partnered with Rulo Strategies on, and I'm going to call it a toolkit, but it's basically a framework for collecting performance measures. And the title of it is Performance Measures for Medication-Assisted Treatment in Correctional Settings. And what it does is it sets forth 12 core performance measures that should be captured. And those include process measures. So things like the assessment rate for substance use disorder, MAT induction and retention rates, and MAT referral rates, and then also outcome measures. So things like the rate of rearrest and the post-release overdose rate. And that framework does a deep dive into all 12 of the recommended performance measures. You can take a look at that. It includes information on what information should be collected, the data elements that should be included, and how often that data should be reported. We also have 3 other documents I want to mention very briefly. We have 2 model laws. One of the models, and actually I think Annie was expert reviewer for both of the models I'm going to mention. The first one I want to talk about is the model access to medication-assisted treatment in correctional facilities. And that one sort of gets to the issue of how do you implement these programs, what things should be done. It includes, I think I saw in the chat that there was a question about doing telehealth, and it does actually include a telemedicine provision in there. And I think Tara might address that question a little more detail in a bit. And then we also have a Model Withdrawal Management Protocol in Correctional Settings Act, which I think Jeff was one of our experts on that model as well. And that one gets into having a protocol for withdrawal management in correctional facilities to assist individuals who might be going through withdrawal when they come into your facility. And then the last resource I want to talk about is for peer support workers in some public safety settings. This is also on our website. You can find them all on our website or links in chat. And this one really deals with how to use peer support workers in your facilities and provides, Tara did an amazing job on this. It's really in depth as far as how to hire peer support workers, how to train them, what duties they should have, how to deal with burnout and things of that nature. So those are all available on our website. And now I will stop talking and actually turn it over to Tara to talk about some of the funding opportunities for these programs.
Terrific. And I think Becky's actually going to put something up on the screen. In the survey that you all submitted when you registered, we got a lot of questions about funding. And I want to be really clear that basic healthcare should not be funded by federal grants, in my personal opinion. But we do want to highlight funding opportunities that are out there, not just to fund MAT or MOUD, but also things like peer support, things like reentry supports, and that transition to the community and the bridge workers that you could fund as people are transitioning. One of the strongest, most robust funding resources that we know out there is a program operated by the Bureau of Justice Assistance. It has a very long name, Comprehensive Opioid Stimulant and Substance Use Site-Based Program. It is not open right now. It will probably come back around and be open as an opportunity that you could apply for. Start looking for it around December. There are 2 ways you can apply, either as a local applicant, so that's a city or a county or a town or a tribe, or you can apply as a state. The funding amount that you can apply for varies. If you're a state applicant, there's a rather large amount that you can apply for. And then depending on the population, whether you're an urban, suburban, or rural community, there are different funding amounts ranging from $1 million to $1.6 million. These are 3-year grants awards without a match. I always like to highlight this grant program because it's a relatively, there's a large number of awards that are given, approximately 72 grant awards each year. And it's been a really great resource for both sheriff's offices as well as their partner agencies, peer recovery support agencies, to partner with sheriff's offices as well as health departments, public health agencies, behavioral health agencies, and so forth to partner on these types of programs. We wanted to highlight that. In addition, we'll put in chat, earlier Carrie referenced this opportunity to do peer-to-peer exchanges. So this opportunity to visit a mentor site who has successfully implemented an MOUD in a corrections facility, and maybe you don't have that and you want to see how it could be done in your agency through the COSIP program, which is the acronym. There are opportunities to do those peer-to-peer exchanges through those programs. We'll also put that in the chat box as well. I wanted to highlight those resources before we get into your questions, which we have a number of fantastic questions. I want to get back to that. And I want to talk a little bit about rural communities. One of the questions we had in chat was, how can a rural community go about successfully implementing an MAT program? And specifically, can a rural community do this successfully through teleservices? I know of a rural jail in Maryland that has been written up a lot in journals, and I'm going to put that link in chat. But does anybody have an experience that they want to highlight within their state? Any of our panelists want to highlight any successful experiences they're aware of? Carrie, I saw you go off mute, so I want to see if you wanted to take that question.
Yeah, and I'll just mention it a little bit different, but so Franklin County, Massachusetts, really small, rural, has done an extraordinary job. I know that BJA, Tara, I know you as well, have really looked at the work that was done there. Again, watching a smaller facility and how they've had to work really much with their community. Jeff talks about that community, that collaboration on that level. Not needing as much with telehealth, but definitely smaller would be a wonderful peer-to-peer. But I do want to mention, in the space of the withdrawal guidelines, so much of that, they talk about telehealth for substance withdrawal as well as for the treatment for MAT. So please know that was one of the focuses. Many of our larger facilities, so much easier to have access to resources to provide medication-assisted treatment and or withdrawal type of treatment. But the guidelines very much take into consideration rural. So if you haven't had a chance to look at it, again, they're very technical, but please know that is an extraordinary resource, not only for your jail administrators, but also for your medical care providers in your facility, as well as your providers in the community and your hospitals. Because especially for rural, as we have to look at the guidelines, and some of these recommendations will be to transport, when they go to the hospital, you want to make sure that your hospitals are aware of the withdrawal guidelines as well, and what type of medications are being recommended, why in fact you may not be able to have that individual return. So please know rural has been, and small jails have been at the forefront, especially on those particular guidelines.
Thank you, Carrie. Annie?
Yeah, thank you. All of Vermont is rural. We only have one county that's federally designated as urban. And so this is my life. What it has highlighted for me is the importance of strengthening the community health system. You must get out of the silo that you're in and make a lot of friends who are very interested, get them very interested in what you're doing, and sell them on what's in it for them, how they can impact the healthcare people returning to their communities. I have spent probably the last 10 years raising that cry and making people understand that their success in this area is our success. So I spend most of my time with the Department of Health, the Department of Vermont Health Access, which is our Medicaid agency, and the Blueprint for Health, which is our strategic local coalition, medical coalitions. They are all at the table with the efforts of the Department of Corrections to receive and give a warm handoff to those individuals releasing from us. And they've got to understand the importance of their seat at the table. We cannot do it by ourselves. It's one thing to start an MOUD program inside of the walls. That's not daunting, but the key to success is outside. It's in the transition. If anybody's interested, we had a 5-year longitudinal survivor study in a partnership with the Department of Vermont Health Access, and it's just been published on the Vermont Corrections website. We have found over time that 70% of the individuals who were prescribed one form or another of MAT inside of our system show up in Medicaid claims within 45 days of release. For a chronic disorder, this is an extraordinary testimony to the fact that we're treating the right people. They see that they have a chronic disorder, and they themselves are motivated upon release. When all of that infrastructure is gone and they're on their own, they are prioritizing their health and wellness to continue their medication and continue accessing services. So that has just really been a big moment of joy for me when we finally completed this analysis and published this, because it makes it all worthwhile, right? There's the proof in the pudding right there that they're doing this. Not medication compliance is one of the top 3 issues of why people end up back in the emergency department across all chronic diseases. We are making a difference, all of us.
Carrie, you did such a wonderful job of describing the evolution of some of our national associations and their thinking around, and one of the questions that came in really asked about state associations and how do we bring our state associations along on that same journey and help them be supportive of implementing within their states. So I'm going to put you on the spot first to talk about how we involve and educate our state associations. So any thoughts on that? And have you seen them evolve?
Great question. So our state associations, National Association has a committee that is all the state executive directors, like myself now in my new role. And again, they all are aware of all of the resolutions. I always provide an update when we meet in February. They'll be meeting here in just a few weeks, and we do talk about the latest initiatives. So as part of the National Sheriff's Association, all of these releases, all of this information is shared. And in fact, several of these executive directors have reached out specifically to say what type of resources are available, how do we start this? And we've actually been in dialogue. So it is a continued conversation. And here's one of the things I would love to share with any of you. If you do feel like you have any resistance or you would like assistance in how do we best message this or bring it to your state, I would very much welcome it and have that opportunity to have a conversation with you. I think we never want to start with the liability issue. That feels like the wrong reason to have to do something, right? We should do it because it's the right thing to do. But sometimes, and that's why we do have to talk about the liability issues, and we highlight the work that's been done nationally, recognizing that, but also too from an 8th Amendment point of view, as well as the Americans with Disabilities Act. So sometimes it's a conversation about understanding change. Sometimes it's about peer-to-peer learning. Sometimes it is about understanding what resources are available. Part of it too is on this conversation, I keep bringing up the MIEP 1115 waivers, which is a longer term process. But if we start to think about if those monies can return to the state, could some of those monies be set aside to actually build up where there are gaps in the community on providing substance use and mental health care? I share this with you. All of our state execs have access to the same materials that I've referenced here today. I continue to be that voice. But again, if you are experiencing some concerns or pushback or just want to learn more about how we could bring some of this knowledge to your state, I'd be happy to have a conversation with you.
Thank you, Carrie. All right. There were a lot of questions about 1115 waivers and what the opportunities are in the future. Regina, I want to punt that question to you first. What are the opportunities that you see as you look out into the future? How do you think, as we see more and more states potentially have their waiver applications approved, how do you think it's going to change the landscape potentially around the MOUD? I just want to give you an opportunity to speak to that.
Sure. The 1115 waivers are allowed for states to apply to use Medicaid funds in correctional settings they otherwise wouldn't have been able to, matching funds from the federal government. The federal government earlier this year issued guidelines for how they would, basically a guideline for what they would do to approve it. So at the time, there were 15 states that had applied, and then some have pulled it back. So just recently, California and Washington State, as I mentioned at the top, just had theirs approved. It allows for 90 days prior to reentry. The 1115 waiver process is really complicated for states, which is probably why there are 15 that have applied, not 50. But there are people who in correctional settings today in every state in the union and DC who are in need of this type of help, but they're not going to get it unless their state provides this 1115 waiver. So there's an opportunity there for states to go through this process. As I mentioned, CMS has laid out, this is what you need to do. But it's still complicated for states. So more and more states will begin to apply. It has to be cost neutral. It has to be evaluated. At the same time, legislation is pending on Capitol Hill that would get rid of the prohibition on use of Medicaid funds for people during incarceration. I believe that is the solution, and I can say that because I don't work for the federal government anymore. In 90 days prior to reentry, people 90 days prior to reentry, that's really important. They should get help, but there are people who show up when they enter jail or prison who also need help and won't otherwise get it until that 90 days before reentry. So good opportunities, great first step, not enough yet.
I
Thank
agree with you,
you.
Regina. Sorry, Tara.
Yeah, anything else you want to add, Andy? No,
I was going to say, I just agree wholeheartedly with you. It's a Band-Aid. It's a removal of a barrier, but not really. I've been at this for, I think, 7 years, submitting an 1115 waiver exception. Vermont plan was not accepted because ours was too progressive, because we took a much bigger slice and they were not willing to go with that. And we were told you have to dial it back to do what California's plan was. But it is a really big lift, and that's where we're getting stuck now, is that because it's with the Department of Vermont Health Access, our Medicaid agency, for us, we will also be running a dual program. So we have a contractor environment now. So there's a per inmate per month contractor cost. And then if we get 1115 waiver, we're going to be having to run billing codes, et cetera. Then it's DEVA building up the infrastructure of auditing and evaluating and having these people part of the Medicaid system. So it is a giant braiding and blending. And I think that it's the most complicated way to go about it. And the simplest way is what she said, Reentry Act.
Sherry?
So real quick, I totally agree with Regina, and we can share the link. The task force that I mentioned earlier, back in 2020, the NACO and national sheriffs and then major counties released their report on the federal Medicaid inmate exclusion policy that is there. One of the pieces that we put in there was also the legal issue, right? And again, we want people to do things because they're right, but sometimes there is a legal issue there. But we can put that link in there as well. I will tell you, I worked on this with the national sheriffs, continue to, and here in Massachusetts, we've been working on it now for about 3.5 years. And I have to tell you, is it a heavy list? Extraordinary. It has been really this extraordinary also collaboration from the get-go. We have had all of the key players. This has been, everybody is at the table, and we are seeing just again, everybody has to be at the table. Extraordinary lift, but I think there are going to be some really great takeaways from the states that actually, once for California and Washington right now, ours is actually just in the public comment period, again, to mirror a little bit more of California. But there are going to be some really good takeaways about how to do this and who needs to be at the table. It's one part of the solution. So I say, ultimately, we want people to have all their federal benefits. There are going to be different lanes to get there. One might be legal, one might be to make changes at the congressional level, some might be within your state, and then an 1115 waiver. But I do believe this, we are seeing such extraordinary change and recognizing of our nation's jails and support for our nation's jails, that if there ever was a time, this is it. And so I'm really proud of the work, but again, more to be done. And there's a lot of great work that is out there. And if you want to learn more, just always feel free to reach out.
Thank you. Regina, I see your hand raised. I'm going to hand it back to you to begin our final comments. So I'll pass the baton back to you.
Thanks. So I just wanted to say one other thing about that. While it's critically important we have treatment and corrections, I think you've heard from every panelist today about how this is a community-based issue as well. Because what you need to do is to make sure that you can, when upon reentry, people have a place to go. And so we shouldn't be we need to build up these systems simultaneously. And I think that with the funding that Tara's talked about, along with the opioid litigation funds that are going to the states, those are going to help build up those community-based systems. And I think we just released a report called Met, Money, Ego, and Turf. That personifies every piece of this. Not enough money, but still there's a lot of ego and a lot of turf. And so it's incumbent upon all of us to reduce the ego and the turf so that we're building up systems simultaneously. So what I wanted to do is give each of the panelists an opportunity to give closing remarks and reply to this question. So given what you know now and the fact that you've had decades of expertise and experience, what's the number one piece of advice that you would give yourself back when you started implementing the work that you're doing? So if you were going to talk to your junior self, what would you say? And I'll start with Annie.
I'm laughing here because that's a really great question. I have to say that one of the images that I hold in my head every day, I don't know if others are familiar with it, it was the famous statue in New York City on Wall Street, Fearless Girl. And that's what I try to do every day. So I would tell myself to just continue to be that, because you can't be reckless. There's a difference between being reckless and fearless. To be a leader, you have to have some degree and tolerance of representing what people can't see. And you have to embody that for other people. Otherwise, they're not going to follow you. And you have to find out what that special sauce is for each of your audiences to get to that tipping point where you finally have people following and actually getting in front of you and blocking and pairing for you and doing your work for you, because you can't do it alone. So that's my metaphor, is fearless girl standing in front of the Wall Street Bowl. I would tell myself over and over again to do exactly the same thing. I don't have any regrets. I'm not here to make friends. I'm here to make a difference.
Great. Thanks, Annie. Jeff?
Wow, this is a tough one. I've been doing this for 33 years. What we were doing in the field of corrections wasn't working, guys. and we need to be willing to think outside of the box and do things differently than we were doing. I think that is a huge piece of it, and being willing to, at least for me, I am blessed to have a very strong group of people surrounding me that push me outside of my comfort zone almost every single day. And I think that is something that once you get comfortable with that and trying some unique things and doing things that are unique and outside of the box, and a couple of those hit, and Carrie can tell you, we talk about winning. We like to win here in Franklin County, but many of the ideas that really pushed me outside of my comfort zone and made me think outside of the box are things that are now considered to be national best practices. I think just be willing to think outside of the box and do things differently than you're seeing other places do it is a big piece of this.
Thanks, Jeff. Carrie?
Thank you. I think the one message that I would tell myself then and now is you're not in this alone. It's all about collaboration. And when you work with everyone and everyone's at the table, you can be brave and you can take on projects. And sometimes there are barriers, but when you know you have collaborative partners that share that vision and you're all willing to be at the table, like Jeff was talking about, it's okay to be brave. And most of all, when you know it's the right thing, and it's all about saving lives, it's easy to stay in this space and to be champions for all the extraordinary people who do this every single day in our nation's jails, because they are extraordinary guardians and extraordinary individuals. And this is about making it safer and better for all who live and work in our correctional facilities. And I always say again, it's all about improving outcomes for everyone. Collaboration and makes it easier to be brave.
Great. Thanks. Yeah, and keeping in mind why we're doing this. You know, I've got pictures in my office all the time about the people that I know who've lost their lives to this ridiculous and awful scourge. With that, I will turn it back over to Becky.
Thank you so much, everyone, and thank you for being here today. What a great discussion. A special thanks to our moderator, Regina, for sharing her expertise and guiding this discussion, and of course to all of our experts, Annie, Carrie, and Jeff, for sharing your experiences with us. We really appreciate it. So you will see that we posted a survey in the chat. This is just a feedback survey. Your feedback is really important to us, so I ask that you click on that link before you disconnect and just take 5 minutes to answer a few questions so we can continually improve our support for you all and future knowledge labs as well. So thank you for taking a few minutes to do that. The recording will be made available on the Knowledge Labs tab on LAPA's website, along with all the resources that we shared too. So including additional previously recorded information on the topic from some of our speakers too. We will send all that information out via email once it is available, and we'll post it on the website as well. We strongly encourage you, if you're not already, to sign up for LAPA's updates. You can do so on LAPA's website. At the bottom of the page where it reads join our mailing list. That way you'll find out about future knowledge labs and all the other resources that LAPA has on this topic and related topics. I want to thank you again to ONDCP for funding and otherwise supporting this event and for being here today. Again, you can find the recordings for our past knowledge labs on harm reduction, overdose prevention, and overdose fatality reviews, which were held in the last couple of months. Those are on our website. And I also posted in the chat, but our next knowledge lab will be on school response to drugs and drug-related incidents. And that is scheduled for October 11th, so next month. And the registration link is in the chat as well. So thank you again to all of our panelists and our moderator, and to the LAPA staff and ONDCP for joining us here today, and for all of you for being here today and really giving us a great conversation. So thank you and have a great day.